Good morning, everybody. Thanks for joining us. You're having such rich conversations. I was reluctant to interrupt you. I'm Kamran Abbasi, Editor-in-Chief of the BMJ. I'm delighted to be here to MC today on behalf of Imperial Institute of Global Health Innovation and our colleagues at the Red Cross. And we're here to talk about equity, moving towards equity in health, and specifically, it says here, and I hope you've all got this, to set priorities to improve health equity, share examples of best practice, challenge thinking, and foster collaboration across academia, government, and charitable sector. And I think we all know that equity is probably the biggest issue globally that we need to address. I mean, on the Today programme this morning, they were talking about data and food and how that might, from supermarket data, how that might help people advise them better about their food choices. Now, we're going to talk about technology shortly, a little later on this morning, but of course, there are benefits and harms, and we need to talk about both sides of those things. But food and feeding people is a particular issue around equity. We have food banks in the UK, which many of us can't believe that we have now, and they're often produced, supported by the third sector. I was in Brazil recently, where a Michelin star chef has opened a community hall where his wife feeds landless people that live in a community there. And so it's really impressive, the work that's being done outside government to help us improve equity. But I hope we dissect a whole range of issues today. A bit of housekeeping from me before we go to our really excellent and amazing, actually, panel of speakers for today. There are no fire alarms planned, importantly. So if there is one, we need to get out. And the fire exits are at the back, the back there and at the front here as well. We're going to have a couple of speakers to begin with. Then there'll be a panel discussion. We'll have a coffee breakout sessions in the latter half of the morning, and then in the afternoon we'll have more breakout sessions and another panel discussion before we wrap up. So that's the plan for the day. I'm really looking forward to it. There's some really fascinating issues we're going to be addressing, and I hope you enjoy them as much as I'm looking forward to them. We are going to take questions, and so be prepared to ask questions and make comments as well during the course of the day. So without further ado, let's go to our first speaker. He probably needs no introduction, considering what's been happening over the last week. So we're rather privileged to have him here. And it's Lord Darzi, pioneering surgeon and co-director of the Institute of Global Health Innovation at Imperial College London. And as we all know, much more than that as well. So Lord Darzi, over to you.
Thank you. Thank you, Kamran, and warm welcome to everyone attending the Equity Summit today. It's an honor to have you all here at Imperial College, South Kensington campus, and hosting many of you at this critical event. We're delighted once again to partner with the British Red Cross on a topic that strikes the heart of our work: health equity. The elimination of avoidable and unjust differences in health outcomes across different groups. Over the past months, as you may know, I've been deeply engaged in reviewing the state of the NHS. And it's been challenging, eye-opening process, one that forced me to look beyond the surface of the headline statistics to explore deeper issues of inequality and variations in care. And what I found was quite frankly shocking. For instance, children starting primary school are twice as likely to be obese if they come from the poorest 10% of society compared to their peers from the wealthiest backgrounds. From such a young age, the path to diverging health outcomes is already set, and that divide only widens with time. Although my review focused primarily on NHS performance, I recognize the inextricable links between health outcomes and the broader social determinants of health, issues like housing, food security, and education. And I can tell you how pleased I am that Sir Michael Marmot, a true expert in these areas, will be speaking to those wider factors shortly. For now, I'll turn to what I uncovered in the NHS itself. What became clear is this: the NHS is not delivering equally for everyone. In fact, it's often those in the most deprived communities who are being left behind. People in the poorest areas are twice as likely to wait over a year for non-urgent treatment. The rate of undiagnosed diabetes is double for those in the lowest income groups compared to the wealthiest. Meanwhile, A&E departments and emergency services bear the brunt, with far higher attendance from poorer communities, an indication that the NHS is failing to provide effective, proactive care for our most vulnerable. The same holds true for ethnic disparities. Post-pandemic, people from Asian backgrounds have faced significantly longer waits for care compared to their white counterparts. Black patients saw a 19% drop in cataract procedures, disproportionately higher than the white population. In mental health services, Black people are nearly 4 times as likely to be sectioned under the Mental Health Act, yet they face more barriers when trying to access early intervention services, such as talking therapies. Once again, those at the margins aren't receiving the care they need early enough to prevent crises situations. In my investigation, I also looked specifically at 3 vulnerable groups: people experiencing homelessness, people with learning disabilities, and unpaid carers. People who are homeless often struggle to access primary care, facing stigma and discrimination both within the NHS and society at large. As a result, they are far more likely to end up in A&E, 4 times as many attendants, and 8 times the number of inpatient admissions compared to the general population. The tragedy is compounded by the fact that the average age of death for someone experiencing homelessness is in their 40s. For people with learning disabilities, life expectancy is alarmingly low. Less than half live to see their 65th birthday. Many die from preventable or treatable causes, despite interventions like GP health checks. Yet even those checks fall short, as only a quarter of people with learning disabilities are registered with their GPs as such. Let me turn now to carers, the unsung heroes of our society. There are 4.7 million unpaid carers in England, many of whom have their own health needs, with 28% living with a disability themselves. Astonishingly, 30% of carers waiting for hospital treatment or assessments have been doing so for over a year. So who cares for the carers? The NHS should, but clearly it often doesn't. My review was rapid, and it focused heavily on data. That's the only way to deliver something in 9 weeks. But behind every statistics lies a story. Someone's mother, someone's father, someone's child. This is not just about numbers, it's about real lives across our nation, from Blackpool to Brighton, from Newquay to Newcastle. We cannot simply claim that the NHS serves all. It must actively reach out to those in greatest needs. Today you will hear examples of where this is already happening, where the NHS is striving towards equity. The challenge before us is to scale those successes, to bring the best of the NHS to all parts of the NHS, as the Secretary of State for Health and Social Care has aptly said. To truly deliver high-quality care for all, which was the motto of my report in 2008, the NHS must place health equity at the heart of its mission. Only then we can ensure that no one is left behind. Thank you again for the time, and thank you for being here.
Thank you very much. First of all, congratulations on your report. Remarkable effort in 9 weeks, and really, a very excellent diagnosis of the problems. You've kindly agreed to take a couple of questions.
Yep.
So I'm going to open it up to the floor rather than take that opportunity myself. Yeah, one at the back, please. We've got a microphone for you. Yeah.
Hi. My name is Kim Frost. I'm at Health Innovation Yorkshire and Humber, and thank you so much. The amazing work that you've done, first of all, sort of goes without saying. You sort of touched on it very at the end, really, when you said that it sort of mirrored the report that you did in 2008. So, and this is not, localised to this, but I feel the same conversation happens so often. So how can we break this cycle? What can we do?
Well,
good question.
It's a good question. Let me just, 2008 report, we were in a better place, to be fair, when we were back, despite the high quality care for all. What I was trying to do then was focus the minds from shifting the mindset from targets, actual fact, into quality should be the organizing principle of the NHS. That's really, I had this, being an academic clinician, I had this issue, quantity is fine, but quality is as important. You can't just divorce the two. And that is sadly the divergence which was happening back in the NHS plan, at the end of the NHS plan. This is a very, very different story, really, truly very different story than it was then. Things have deteriorated, and the report is littered with examples of that. The ones that really shocked me, there's 100,000 children below the age of 2, below the age of 2, waiting in A&E for 6 hours. There's 100,000 young and adolescents with mental health waiting for more than 1 year to access mental health services. When you see that, that's not just quality, that's quantity. There's something seriously wrong. So we're dealing with a completely different set of challenges, much more severe, much more deep this time than we did the last time.
I suppose the question a little bit is how, you're absolutely right. The situation is much more shocking than it was in 2008. How can we actually begin to address the challenges, do you think? I appreciate that's beyond the scope of your review.
Well, that's coming for the next NHS plan.
Yeah.
But what I've learned in my life trying to address some of these issues, and I've been very privileged to be asked to do the high quality care for all, served under Gordon Brown's government, and then subsequently, you may or may not remember, by the way, I did a piece of work before, which was the London Framework for Action. With Londoners, we managed to completely transform stroke services. Actually became a Harvard Business School case study. I've never thought something from the NHS would be published in the Harvard Business School. So, we're not short of intellect, we're not short of people who are passionate about the health service, but how do you ignite that? How do you engage them? How do you give them the tools? And how do you stop making them look up, because there is no one up there, look out towards your patient? That's really what matters if you happen to be working in the health service. I promise you, never look up. I tried it a number of times. It's always vacant.
Thank you. Are you able to take one more question?
Yeah.
Yeah, another question. Yes. Here, gentleman in the white shirt, green tie. It's a challenge for the microphone team.
Thank you. My name's Roger. I'm from South Central Ambulance Service. I chair the patient panel. I'm a volunteer patient. So my question is, what are Lord Darzi's thoughts on large provider trusts and large commissioning integrated care organisations, and do they give an equity of provision to patients?
That's a good question, and I suspect you know the answer to that. That's why you're asking the question. At the end of the day, I work in a place like Imperial. I need to have the evidence, but I agree with you. We should put a hypothesis out there whether the size and the correlation with the output and quality works or doesn't work. Historically, we've been through 2 decades of mergers and mergers and mergers. Everything else got bigger and bigger and bigger. Whether that you could accurately point to that as one of the reasons. There are many other reasons, but that is something to be investigated and to be looked at, and I very much hope will be in the remit of the NHS plan. I agree with you, there's something there which needs to be explained. Yeah.
Thank you very much.
Thank you.
And